Welcome everyone. I would like to present my PhD topic, which is improving the success rate in surgery of chronic middle ear diseases. Next to my PhD program, I'm working in a department of otorhinolaryngology in Bajcsy-Zsilinszky Hospital, and we have many patients with middle ear diseases, and there are many therapeutic options, but there is a lack of international and national guidelines. So my vision is to clinicians use the most effective therapeutic options in the field of middle ear surgery. And to achieve this vision, my mission is investigate the therapeutic options and create high-level evidence. To achieve my visions, here is two specific goals, and I choose the meta-analysis for methods. The effectiveness of the mastoid obliteration in the cholesteatoma surgery compared to the canal wall-up mastoidectomy is my first research. About the background, the cholesteatoma is a dangerous disease, and because there are many life-threatening complications. The incidence is between 3 to 12 per 100,000 population, and the recurrence rate is very high, 35%. So I would like to compare the conventional method, the canal wall-up technique, to the obliteration techniques, and our aim is to evaluate the effectiveness of the mastoid obliteration, because we think the mastoid obliteration can reduce the recurrent and residual diseases. Here is our clinical question and our PICO. The intervention group is the mastoid obliteration, the comparison is the canal wall-up technique without obliteration, and our main outcome is the recurrency and the residual rates. And the secondary outcome would be the hearing results, quality of life, the hearing discharge, and complication rates. The research and systematic search was conducted for databases, and we use this search key. During the process, we have 31 eligible articles after the title and abstract selection, and in the end we have 11 articles. And I would like to present our main outcome, the residual and recurrence disease. You can see in this forest plot the mastoid obliteration reduces the recurrent and residual disease significantly compared to the conventional method, and the heterogeneity was under threshold. And now I would like to talk about the strengths and limitations. This is the very first comprehensive study about this topic, and more than 2,000 patients' data was assessed, and the result was significant statistically. Multiple database was searched during the process. However, there are limitations. Only retrospective cohort studies were included to the study, and the heterogeneity regarding the material for use obliteration is high, and the surgical techniques are not uniformized, and we could have only 7 articles to the research. And now I would like to talk about the clinical and research implication. So if the clinicians would use the obliteration technique, it would decrease the number of the recurrence, and it would be fewer reoperation per year, and it causes better quality of life for the patients. It saves time and resources, and there is a beneficial in a financial way as well. And I hope this study will encourage the clinicians and surgeons to use obliterative techniques and provide more prospective data in this topic. And now I would like to talk about my second project, the predictive factors of the type 1 tympanoplasty. The perforation of the tympanic membrane is a very common otologic problem, and it can cause quality of life problems and hearing impairment. You can see the definition of the type 1 tympanoplasty, which is the cure of the tympanic perforation. The tympanoplasty is a surgical approach performed to repair the perforated tympanic membrane without the need to reconstruct the ossicles. The prevalence of the disease is 9 per 1,000 population, according to a German study for 2008. The success rate is usually around 80%, but the range is very high. The number can be 40 or even 90. Because various influencing factors have an impact on the outcome, and we would like to evaluate the predictive value of the factors and identify the most correlating ones. Here is our PECO, and we have many exposure and comparator groups. These are based on the key articles, and these are the most important according to these articles. Our main outcome would be the success rate. And what is the clinical implication in this study? After this study, we could tell to the patient how effective this procedure. For example, if there is a patient with high chance to success, we can use a minimal invasive technique which has a lower effectiveness, but it's gonna be succeed anyway. Or if there is a patient with very low chance, maybe we should delay the surgery, give some advice to the patients, for example, quit smoking, and maybe we should treat the wet and discharging ear, and later do the operation. And here is the systematic search, what was conducted for 3 databases, and we use this search key. And here are the numbers. In the beginning it was 15,000 articles, and now duplicate removal is in process. This is just an estimated number. And here are the specific goals again. I would like to submit the first study in June and the second one in August. And thank you so much for your attention. I would like to say goodbye with this quote: the improvement of understanding is for 2 ends. First is our own increase of knowledge. Secondly, to enable us to deliver that knowledge to others. And I'm happy to answer your question.
I'm a gastroenterologist, so I'm very happy to ask about the topic. If you go back, can we go back 2 slides? To the forest plot of your first project, is that you say that, so you've got the outcome for which you did the forest plot is residual and recurrent disease. My question relates to the time frame of recurrent disease. Was it recurrent disease in, let's say, 3 months for all studies? Was it different time frames for recurrent disease? Because it's a composite endpoint, isn't it?
Yes. All of the study has more than a year after the operation, and it was our criteria to have only those articles, they have this deadline, and usually the articles have 2 or 3 years after the surgery, but it's have to be after 1 year.
And so the question is then, when do you see the recurrent disease, if you see it?
Actually, we wait after 1 year, so it's between 1 and 5 years gonna be the most of the recurrent diseases, and after 5 years it's not gonna be. So that's why we hit up these deadlines.
So usually after a year,
yes,
you see recurrent disease if there's recurrent disease.
Yes.
Perfect. Thank you.
Okay, if I may have your question, fantastic progress again. I think presenting forest plots after 3 months is amazing. I have a question regarding your first meta-analysis about the obliteration, or what was the technique? So
the canal up technique versus the obliterative.
The obliterative, but
yes,
your results support the obliterative technique. But of course, you have a lot of retrospective studies, or out of the 7, I don't know, you did not mention how many of the studies are retrospective, and of course you will do...
All of them, sadly. There are no RCTs and prospective, yes. That's why I would like to emphasize that it's very important to publish articles, prospectives about progressive studies in this one, because it's not that strong.
Are there any ongoing studies regarding this question, RCTs?
None. But maybe it will be after this.
Of course, you will do the risk of bias assessment, but would you recommend this technique for the otolaryngologist to use it, or is there any obstacle to use this technique?
It increased the time of the surgery, and some surgeons don't like to use it because if there is a recurrence after the obliteration, maybe it's harder to operate again, but still 9% or more less recurrence will be, so it's worth it to do. Even if it's gonna be a longer period in the surgery room, it's still worth it because one surgery it costs more time and more money.